You know, when you buy a brand new hair dryer, there's always that giant bright yellow tag permanently attached to the cord.
Oh, yeah. The one with the illustration that explicitly says,
Yeah.
do not use in the bathtub.
Right, exactly. A warning that feels completely obvious, yet it's there because the danger is technically real.
Even if the circumstances required to trigger it are, well, incredibly specific and entirely avoidable.
Yeah. And today, we're looking at the medical equivalent of that hairdryer warning. Welcome to the deep dive. We are talking about the cardiac safety of ondansetron.
Which is, it's ubiquitous in virtually any clinical setting for nausea and vomiting.
Oh, absolutely. Anyone listening has either prescribed it, administered it, or, taken it themselves at some point.
Right, it's everywhere.
But hanging over this incredibly common drug is this sort of dark cloud. It's driven by a strict FDA black box warning about QT prolongation and the risk of a potentially fatal arrhythmia called torsades de pointe.
Which leaves clinicians in a really frustrating bind, honestly.
Because it's so effective, right?
Exactly. We have this highly effective antiemetic, but there's a lingering hesitation to use it, or a tendency to just over-monitor patients who receive it, simply because of that label.
So our mission today is to untangle that scary warning label from the actual clinical reality. We want to figure out if this is a danger of everyday use or strictly an extreme edge case.
And to do that, we are synthesizing a massive stack of recent literature.
Yeah, we're pulling from a 2022 retrospective surgical cohort by Nuttall and colleagues, also a 2026 systematic review of randomized trials by Garcia's team.
Right, and some really fascinating 2024 prospective emergency department data by Yuruk-Masurliulu.
But before we get into the numbers, to ground this data, we should probably briefly review the mechanism of the warning itself.
Yeah, that's a good idea. So the concern basically centers on ventricular repolarization.
Which is measured by the QT interval on an ECG, right?
Correct. The QT interval represents the time it takes for the ventricles to depolarize and then reset for the next beat. It's a vulnerable window for the heart.
So if a drug blocks the potassium channels involved in that repolarization phase, it kind of drags that interval out.
Exactly. The refractory period lengthens. And that creates a setup where an early after depolarization can trigger torsades de pointe.
Which is that chaotic twisting rhythm that effectively stops the heart from pumping blood.
Yeah. It is a true medical emergency that can quickly deteriorate into ventricular fibrillation and death.
Wow. So the physiological pathway is pretty clear.
It is, which is why the warning exists in the first place.
Yeah.
But the disconnect between the theoretical fear of the event and the reality of the clinical data is, honestly, it's staggering.
Well, let's look at the actual numbers to see that disconnect. I mean, the 2022 data from Nuttall and colleagues out of the Mayo Clinic provides a perfect starting point.
Yeah, they retrospectively analyzed over 32,000 surgical patients.
32,000, that's a huge cohort.
It's massive. And these were patients who were given standard 4-milligram doses of intravenous ondansetron.
Okay, so standard dose, huge sample size. What did they find?
Out of that entire cohort of 32,000 patients, the number who developed torsades de pointe or died as a direct result of the medication was exactly 0.
Wait, 0. But I'm looking at the breakdown of those charts, and there were adverse events recorded during the study period, weren't there?
There were. There were 46 cases of monomorphic ventricular tachycardia and 32 deaths.
Okay, so someone skimming the abstract might just assume the drug was responsible for those.
Exactly. But if you dig into the patient histories, every single one of those 46 VT episodes was precipitated by pre-existing cardiovascular disease.
Oh, wow.
Yeah. Half of those patients already had documented VT in their charts before the ondansetron was even pushed.
So the drug didn't cause the arrhythmia. Their underlying structural heart disease did.
Right. And the 32 deaths followed the exact same pattern. Every single one was judged to be the result of their pre-existing pathology.
So the baseline risk of the drug causing a completely de novo fatal arrhythmia in that surgical population was virtually non-existent.
Practically 0, yeah.
Okay, but that's a single, albeit massive, hospital system. What about across different settings?
That's where Garcia's 2026 systematic review comes in. It broadens the scope significantly.
Right. They aggregated data from a ton of trials, didn't they?
Yeah, 170 different randomized controlled trials. That encompasses over 23,000 patients across a wide variety of clinical settings.
And did their findings mirror the Mayo Clinic data?
Perfectly. They tracked major adverse cardiac events, so death, cardiac arrest, arrhythmias, and ondansetron simply was not associated with increased mortality or any of those events.
You know, the methodology section of the Garcia paper is actually quite revealing to me.
Oh, how so?
Well, the researchers had pre-registered all these complex meta-analyses to figure out exactly how the drug was causing these heart problems.
Oh, right, because they assumed they'd find a signal.
Exactly, but they ended up having to abandon their own statistical models because there were so few adverse events that the math literally broke down.
Yeah, you can't really run a trend analysis on zero.
Right. Across all those trials, only 7 major adverse events were reported, all deaths, and none were linked to the study drug.
It's the statistical equivalent of a ghost hunt. The signal they were looking for just wasn't there.
Which makes the clinical reputation of this drug so baffling to me. I mean, if the absolute risk is so low that researchers can't even get statistical significance, why do some texts explicitly state that ondansetron carries a relatively higher risk of torsades than other antiemetics?
It's a great question.
Because you will see clinicians terrified to give Zofran, but they will happily order low-dose haloperidol or droperidol for nausea.
Right, even though those are heavy-duty antipsychotics with known QT prolonging properties.
Exactly. So where is this fear coming from?
Well, the reputation isn't totally fabricated. If you really dig deep into the clinical literature, you will find a handful of documented cases where ondansetron was definitively linked to torsades.
A handful.
Yeah, at least 5 and a few of these even happened at those standard low 4-milligram doses.
Okay, so the hairdryer did actually fall in the bathtub a few times.
It did. But the secret to understanding why those incredibly rare events happen isn't just about the ondansetron molecule itself.
What is it about, then?
It's about the pharmacokinetics of delivery. The literature points heavily toward the speed of administration.
The speed, like how fast it's injected.
Exactly. The risk of QT prolongation is almost exclusively associated with rapid intravenous administration.
So we're talking about a nurse or physician taking a syringe of IV ondansetron and pushing it directly into the line within, what, 1 to 2 minutes?
Right. And that causes a transient massive spike in the peak serum concentration.
Ah, I see.
That sudden, overwhelming blockade of the potassium channels hitting the myocardium all at once is what directly drives the QT interval to stretch to a dangerous degree.
It's basically the difference between taking a shot of pure espresso versus sipping a large latte over the course of an hour.
That's a great way to put it.
Because the total amount of caffeine entering your system is exactly the same, but taking it all to the dome in 2 seconds causes that sudden spike that makes your heart race and your hands shake.
Exactly. The total dose isn't the primary enemy here. The peak concentration is. If you dump it all in at once, the heart's electrical system is stressed.
So the mitigation strategy then must be incredibly simple.
It really is. You just have to sick the medication.
How do you do that in practice?
You can virtually eliminate this already microscopic risk by administering the intravenous dose as a slow infusion over 10 to 15 minutes rather than a rapid push.
Okay, that makes sense.
Or, even better, utilizing the sublingual oral disintegrating tablet, the ODT.
Now wait, there is a pervasive misconception about how the ODT actually works that we should clear up.
Oh, for sure.
Because it melts instantly under the tongue. Patients, and honestly, even some clinicians, assume it's absorbing straight through the oral mucosa directly into the systemic circulation, like sublingual nitroglycerin.
Right, but the clinical pharmacokinetic data shows that is not what is happening at all.
It's not.
No, ondansetron ODT is not primarily absorbed transmucosally. The patient is actually swallowing that dissolved liquid with their saliva.
Oh, I see.
Yeah, and it is being absorbed lower down in the gastrointestinal tract.
Which means it's subject to first-pass metabolism.
Exactly.
It has to pass through the hepatic portal system, where the liver filters out a significant portion of the drug before it ever reaches the main bloodstream and the heart.
Right, bringing the bioavailability of the dissolving tablet down to roughly 50 to 70%.
Okay, so an 8-milligram oral disintegrating tablet is functionally providing the systemic exposure of a 4-milligram IV dose.
Precisely.
But more importantly for the cardiac safety profile, because it relies on gut absorption and hepatic processing, the onset is significantly slower, right?
Exactly. The peak serum concentration is completely blunted. You bypass that dangerous IV spike entirely.
You are sipping the latte.
You're sipping the latte. Physiologically, we know that rapid IV push causes a transient spike, and we know that ODT or slow infusion prevents it.
But we have to look at how this plays out in a practical, real-world environment.
Right. Because in a chaotic emergency department, staff don't always have 10 minutes to hang a slow IV drip for a routine complaint of nausea.
Yeah, I imagine the drug is frequently given as a rapid push just for efficiency.
It is. And the 2024 prospective study by Yurik Masurliulu and colleagues looked specifically at that exact ED scenario.
Oh, perfect. What did they do?
They took 435 adult patients, administered Ondansetron, and tracked their ECGs meticulously, baseline that at 5, 15, and 30 minutes post-administration.
So they were trying to catch that transient pharmacokinetic spike in the act?
Exactly, and they found exactly what the models predicted. The peak QT prolongation occurred right at the 5-minute mark.
Okay, but the magnitude of that spike is the real takeaway here, right?
Oh, absolutely. The mean increase in the QT interval across those 435 patients was a mere 7.9 milliseconds.
7.9. To put that into perspective for you listening, a single blink of a human eye takes about 100 to 150 milliseconds.
Wow.
Yeah, we are talking about stretching the heart's repolarization time by a fraction of a blink.
That's a crazy comparison, but it's accurate. Regulatory bodies provide excellent context for that number too.
What do they say?
The International Council for Harmonization guidelines classify a change in the QT interval of less than 5 milliseconds as negligible,
Okay.
and a change of more than 20 milliseconds as a significant threshold of clinical concern.
So a 7.9 millisecond bump is what, right in the middle?
It's categorized as above negligible but below significant.
So it's basically a mathematical technicality. It simply doesn't stretch the vulnerable refractory period enough to allow an R-on-T phenomenon to actually occur.
Exactly.
Yeah.
Which is where a premature ventricular beat lands on the T wave. It just doesn't stretch it enough.
And in the Eureka Serlulu study, even among the patients who received the higher 8 milligram IV doses, absolutely no cardiac conduction problems or arrhythmias were observed.
None at all. Which brings us to the whole clinical debate surrounding QTC monitoring and hospital protocols.
Actually, before we talk protocols, we should probably define QTC for anyone who might be rusty on the terminology.
Good point.
We've been talking about the QT interval, but clinical literature and ECG machines always spit out the QTC, the C standing for corrected.
Right, because the QT interval naturally shortens when the heart rate speeds up and lengthens when the heart rate slows down.
So it's a moving target.
Very much so. If you just measure the raw QT time, a patient with a heart rate of 100 beats per minute will look vastly different than a patient at 60 beats per minute.
Making it impossible to establish a standard baseline for risk.
Exactly. The QTC applies a mathematical formula, most commonly Bazette's formula, to correct the interval based on the patient's heart rate.
Giving clinicians a standardized number to evaluate regardless of how fast the heart is beating.
Precisely.
Okay, so if the corrected spike is only 7.9 milliseconds, and researchers can't even find enough adverse events to run a meta-analysis on tens of thousands of patients,
Yep.
why do some hospital protocols obsess over checking a baseline and serial QPC before they allow nursing staff to administer Zofran?
Well, it really highlights the tension between defensive medicine and evidence-based practical medicine.
How so?
Checking an admission ECG is standard, high-yield practice for any sick adult being admitted to the hospital or the ED.
Sure, you want a baseline to check for ischemia, which can cause nausea on its own.
Right. And you want to identify untreated hypokalemia or hypomagnesemia.
Because low potassium or magnesium makes the myocardial cell membrane incredibly unstable.
Exactly. If a patient has severe uncorrected hypokalemia, that is a true, absolute contraindication for ondansetron.
So doing an initial baseline ECG is just smart medicine.
It is. But instituting protocols that demand serial ECG monitoring is a different story.
Meaning holding the medication, hooking the patient up, giving the drug, and then keeping them on the monitor to recheck their QTC multiple times.
Yeah, doing all that purely for a standard dose of ondansetron is a massive drain on resources.
I can imagine.
It negatively impacts emergency patient flow, it ties up nursing staff, and wastes healthcare dollars monitoring a risk that is mathematically microscopic.
So for clinicians who want to practice safely but don't want to paralyze their department flow, there must be more elegant solutions than serial 12-lead ECGs.
There are. If a patient is already admitted and on continuous telemetry monitoring, you can use the electronic calipers built into the central monitoring system.
Oh, that's smart.
Yeah, you just check the QTC instantly at the bedside at zero additional cost or time delay.
And what about for patients not on continuous telemetry?
Clinicians can utilize the Tisdale risk score.
The Tisdale score.
Yeah, it is a validated clinical tool that assesses a patient's specific risk factors for QT prolongation, rather than treating every single patient as a high-risk liability.
Breaking down the variables on the Tisdale score really shows how practical it is.
It does.
It assigns points based on things like age over 68, female sex, the use of loop diuretics, an admission potassium level under 3.5, a diagnosis of acute myocardial infarction.
Or if the patient is already taking one or more known QT prolonging medications.
Right. It provides a quantifiable way to stratify risk.
Exactly. So if a 40-year-old male presents with viral gastroenteritis, has normal electrolytes, and isn't taking other QT prolonging drugs, his Tisdale score is essentially 0.
So you can confidently rule out the need for repeat ECGs, administer the drug, treat the nausea, and move on.
You absolutely can.
Synthesizing this massive stack of data, the answer to our initial question is overwhelmingly clear to me. The cardiac safety profile of ondansetron at standard doses is incredibly robust.
Yeah, the dreaded risk of torsades de pointe is not a boogeyman hiding in every tablet.
No, it is almost entirely a mechanical issue linked to rapid IV administration causing transient serum spikes.
Spikes that, even when they do occur, are clinically insignificant for the vast majority of patients with structurally normal hearts and normal electrolytes.
And by simply utilizing the oral disintegrating tablet or slowing down the IV push to 10 or 15 minutes, the risk is effectively negated.
Negated entirely.
So for the clinicians listening, this data is your mandate to optimize department flow. Stop wasting time and resources on serial ECGs for healthy patients receiving standard doses. Use the Tisdale score, treat the nausea, and discharge the patient.
Absolutely.
And for the patients listening, the next time you have the stomach flu and you are letting one of those little tablets dissolve on your tongue, you can do so with absolute confidence. You really don't need to worry about your heart rhythm.
Stepping back from ondansetron specifically, though, this deep dive leaves us with a pretty provocative question about our medical system as a whole.
Oh, what's that?
Well, we've just reviewed mountains of data proving that one of our most commonly used, supposedly high-risk medications is actually incredibly safe when administered with a basic understanding of its pharmacokinetics.
Right.
So how many other highly effective therapies are we underutilizing? Or, how many millions of healthcare dollars are we wasting by over-monitoring patients simply because we've fundamentally misunderstood the context behind a rare warning label?
That is a fascinating point. It really is time to read the data, understand the mechanism, and treat the patient in front of us. Thank you for joining us on this Step Dive. We'll catch you on the next one.